We have 2 physical therapy slides.
Hey guys, thank you so much for coming. I really appreciate all of you coming after work, and I hope that you find this useful. This is the Women in Medicine meeting. It's been going on for 5 to 7 years, a couple of times a year. I try to get women together, and it came out of an interest in meeting people that I saw through referrals, but never ran into anymore at the hospital because we stopped doing grand rounds when the advent of hospitalists. So that's how this all started. And I'm a big fan of women, as most of you know. I think that great things happen when you get a bunch of women together. Everybody's supportive and collaborative, and magic happens. I really love it. So tonight we are lucky enough to have Polly Watson and her nurse practitioner Kate Willis here to talk to us about hormone replacement therapy. So Polly has been a practicing gynecologist in the Raleigh area for 20 years, focusing on menopausal patients. In addition to traditional OBGYN training, she's accredited by the North American Menopause Society and has studied with the International Society for the Study of Women's Sexual Health. That wasn't enough. She's also certified in functional medicine through IFM, the Institute for Functional Medicine. And she opened her practice, which is Hormone Wellness MD, in 2019, and will be presenting tonight on hormone replacement therapy in menopause and beyond. There are folding chairs. Please, I don't know about you, but I can't stand to stand, varicose veins, etc. So grab a folding chair, please, and spread out.
And I'm really excited to introduce Kate Willis. So Kate is a new part of my team. Kate and I have known each other since 2019. Kate's a nurse practitioner who's also IFM certified and soon to be Menopause Society certified. So we're going to do this together. And thank you all for making time out of your busy lives to be here. I hope this will be useful and fun. We have a few fun cartoons to keep it light. So a lot of us are approaching menopause in our lives, and sometimes even in our practices and our professional lives, where it feels like we're falling off a cliff. We know that we weren't trained well in OBGYN residency or family medicine residency. There have been papers that have been published and that have shown that up to 13% of graduates feel comfortable managing menopause. That's it. This is something that half of all of us, half the population is going through. So it's really abysmal. It's sort of like hormones are in this kind of black hole where people just don't want to touch them. And so we really need to kind of change our perspective and not think about we're falling off this cliff. So this is a Torii bridge. My family had the privilege to go to Japan this last summer, and they're all over Japan, and they're framing the view. So we want to think about menopause transition as an opportunity to reframe how we're thinking about our health. So instead of thinking about we're falling off the cliff, this is the beginning of the end, could we use the symptoms that our bodies are experiencing as a catalyst to listen to our bodies and make changes so that we can age healthier moving forward? So we really want to push this reframe rather than the doom and gloom. I got to figure out a better way to do this with my body. Okay, Kate, take it away.
Great. So just so you know, some menopause stats. The average age of menopause in the U.S. is age 51, and 1.3 million women become menopausal each year. So if you're going through menopause this year, you're in very good company. The classic symptoms we think of are these hot flashes and night sweats. Most women will experience those. About half of women will experience mood changes related to menopause, and many women are experiencing vaginal dryness, urinary frequency, frequent urinary tract infections. And we told you we would try to make this fun, so if women ran the world, things would be different. There are so many benefits of hormone replacement therapy. We have a decreased risk for osteoporosis. Hormone therapy is actually FDA approved for the prevention of osteoporosis, not currently approved for the treatment of osteoporosis, but there's a huge loss in bone in those few years following menopause when hormone replacement therapy isn't started. Reduction or elimination of hot flashes is a huge benefit to women in terms of even health risk for future disease, but also current quality of life. Women report better sleep, less brain fog, improved mood, and those vaginal and urinary symptoms can be addressed with hormone replacement therapy as well. There's also, I think we don't have a slide about this. I'll talk about that later.
Okay, cool. So we're going to kind of go through some common misunderstandings about hormone replacement therapy, and we're just going to get the dragon right out of the way and talk about breast cancer first. So many of you will remember that the Women's Health Initiative study back in the early 2000s found a slight bump in breast cancer in women who are using Prem-Pro, so conjugated equine estrogen, so pregnant horse pea urine estrogen, and a synthetic progestogen called medroxyprogesterone acetate. So that was the message that we all got. Oh my God, don't take hormones, they're going to cause cancer. So let's pull up a slide from that study, okay? So yeah, we had 3 more women out of 1,000 over 5 years on this one formulation, right? So that was the one formulation that was studied. 3 women out of 1,000 over 5 years. That's about the same increase in risk in breast cancer of having 1 to 2 glasses of wine a day or not exercising. But did we as a medical community say, hey, what else can we do to lower our cancer risk? No, we just said hormones are bad, don't take them, right? No one talked, right? So 13 bad things happened. No one talked about the 21 good things that happened. And no one talked about this. So the conjugated equine estrogen alone arm, the women who had been hysterectomized and didn't use progestogens for endometrial protection, their breast cancer went down, right? So how do we have this in our head that estrogen causes cancer, estrogen causes cancer? Breast cancer actually went down in that population. So we can never tell a patient there's no risk. We live in a really polluted world. We put a lot of chemicals on our bodies. We're drinking out of plastic. There are a lot of endocrine modulators. But I think we need to do a better job being clear about how much risk was there. And when we're talking about hormone risk, what hormones are we actually talking about? So this was on one formulation, Prem-Pro conjugated equine estrogen with medroxyprogesterone acetate. So we'll give you these slides if you want them, but this is a QR code if you want to take a picture of it. This is the 2022 NAMS position statement on the use of hormone replacement therapy. So if you're not a OBGYN and this is all news to you, this is a really nice document that is from a very mainstream organization. You're not going out on a limb by filing NAMS. Okay. Tell me when I can move. Okay.
Myth number 2 is that hormone replacement therapy is just for hot flashes. I've really already touched on this, but we have hormone receptors through our whole body, and so it makes sense that hormone replacement therapy would benefit beyond just reducing hot flashes. So a little graphic of what's going on. We talked a little bit about the changes that happen in the vagina, vaginal dryness, the urinary tract. Hormone replacement therapy can also improve things like the sensation of having a less intense orgasm, can reduce sexual pain. We're still learning more about cognitive benefit in hormone replacement therapy. What we see is that it appears that when hormone replacement therapy is started earlier, closer to the menopause transition, there is protection, cognitive protection against dementia and Alzheimer's disease later in life. There's also improvement of things like brain fog, short-term memory, and word finding. A lot of women in this transition are complaining of fatigue, waking up in the middle of the night and not being able to fall asleep, or waking up, at 3 a.m. Hormone replacement therapy is really helpful to reduce those symptoms, which can in turn reduce risk for other diseases down the road, and then it can help with mood. So hormone replacement therapy was found to be as effective as an antidepressant in perimenopausal women with depression, and I just think that's an underutilized tool. Not that we should throw out prescriptions of estrogen to anyone who presents with depression and perimenopause, but for the right patient, it could be really a life-changing therapy. There's also some improvement in cardiovascular health. I don't think we have the slide here, but essentially, if hormone replacement therapy is started closer to the menopause transition, there's reduction in development of plaques over the years.
Okay, so kind of, this really pisses me off in medical communities where we just sort of say hormones are. Well, what kind of hormones? What was the route of delivery? What was the progestin used? Was it actual progesterone or was it a progestogen? All of these things matter. So I have like these beautiful peonies that look like they came out of someone's garden versus like plastic wrapped grocery store flowers. I know which one I want, right? So this is a summary of 14 different studies, but this came out of, it sort of started off in maybe 2010. The E3N trial was a cohort study in France, and they looked at breast cancer incidence and who was on what kind of progesterone. And they found that women who were on bioidentical progesterone didn't have the bump in breast cancer that the women who were on a synthetic progestogen did. And so when we're talking about these different chemicals, we need to treat them like different chemicals. They have different behaviors, and they're often, even within hormone experts, we just talk about hormones, and we need to get a lot more specific in our language because we're perpetuating a lot of confusion and fear among people and with patients that maybe isn't necessary. So bioidentical progesterone had basically a flat risk of 1, a relative risk of 1 is a flat risk. So we can never again say you're never going to have breast cancer. But when we compare you to your peer who is not on hormone replacement therapy, the risk of using bioidentical progesterone is about the same. There is a slight risk when we're using things like medroxyprogesterone acetate or norethindrone. And then route of estrogen is really important when we think about thromboembolic risk, right? This is old news. We've known this from observational studies for the last 30 years. And there are just lots of options, right? So we did this talk to the general public last night, but patches, sprays, gels, rings, there is compounded options, but there is a lot of bioidentical FDA-approved options that are available transdermally that don't bump up that thromboembolic risk.
Myth number 4 is that hormone replacement therapy causes weight gain. The truth is we're actually seeing the opposite, that when women are on hormone replacement therapy, they have less visceral adiposity, they have better muscle mass. And so we say that menopausal weight gain is a really complicated web. We have this shift in sex hormones, but we also want to look at other things. So what's going on with movement? What's going on with strength training? So there was a study that came out a few years ago that supported that metabolism really stays steady through our early 60s when muscle mass stays the same. And I think that's something that we are failing to encourage women to do, is to really lift heavy weights and lift weights in a way that really stimulates muscle growth. Nutrition can be, needs to be fine-tuned often in menopause. We develop insulin resistance during perimenopause and menopause. There can be shifts in thyroid health, shifts in the gut microbiome. And then, lots of women are having these sleep disturbances, which can impact cortisol levels, can certainly impact just their overall sense of well-being and whether or not they would even make a healthy choice in terms of food or movement. DHEA levels decline with age. So there's just really a lot that's going on.
And I think we're all flooded as women, if we just take off our doctor hat for a minute and think about us as consumers, we're all flooded with, this is the Galveston diet, or this is the whatever for midlife transition. And I wish it were that simple. I really don't think that it is. I think we have to look at all of these factors and really honor wherever someone's at in their life. And this is also a time when we have a lot more cortisol, and maybe we're launching kids, and maybe we're dealing with older parents, and all of those things are nuanced and important to listen to.
So
sorry.
No, that's okay. There are ways to combat midlife weight gain. As Polly just said, it is not a simple formula. There's not one diet or one type of movement or one thing. So addressing insulin resistance, maybe that's switching up carbohydrates, eating primarily whole food carbohydrates from fruits and vegetables, perhaps bringing in time to eating if appropriate, working on high cortisol, so doing vagus nerve work, taking adaptogens, which are herbs that help our bodies respond to stress. I already talked about the loss of muscle issue, so increasing muscle mass, making sure women are eating adequate protein in perimenopause and menopause. addressing sleep. This is big, and it can be a hard thing to when weight loss is an issue. This is a really important thing to address. So adaptogens are really important, sleep hygiene, and always I'm in this phase where I'm learning more and more about circadian regulation, and I just am encouraging everyone to spend time outside, especially early morning and around twilight, to really support healthy sleep. And here's another little moment to break it up and make you laugh.
So because we're in the more holistic space, we get this a lot from our patients. So a lot of women are under this idea that only the compounding pharmacy can make bioidentical hormones, and everything at the regular pharmacy is terrible. And it's just simply not true. So a bioidentical hormone means that it's a chemical copy of a hormone that existed at one point in your life in your body. So estradiol is a bioidentical hormone, progesterone is a bioidentical hormone, testosterone is a bioidentical hormone. You can get all of those through a regular pharmacy that's in a formulation that's been FDA approved. I think the other big misunderstanding is that a lot of women are wanting a compound version of estradiol and estriol. So there are three main estrogens: estrone, which is the predominant estrogen of menopause; estradiol is the predominant estrogen of our reproductive life; and estriol is the predominant estrogen in pregnancy. And so it was thought about 20 plus years ago that estriol acts on estrogen receptor beta on the breast. And so if you combined estradiol with estriol, you were therefore protecting the breast. So I think that's where that came from. I don't know that that's held up in the studies, but I think a lot of women think that they're getting this custom compounded formulation that was made exactly for them, which really they're probably getting an 80-20 estriol, estradiol formulation. And they come to me and they say, why do I still have hot flashes? Because they're on 80% estrogen break and only 20% estrogen gas, and it's not enough to treat their symptoms. So we just kind of wanted to, I think the general public has this as a misunderstanding. We run into that a lot.
Myth number 6, if I'm on hormone replacement therapy, my vagina is fine. So I say this is like a half myth, because the truth is that for most women that are on systemic hormone replacement therapy, their vaginal and urinary symptoms will improve. But for about 15% of women that are on systemic hormone replacement therapy, their vagina is not fine. How do you get it fine? That's a great question. So lots of changes that happen to the vagina in menopause. So there's a change in pH, so odor can change. You can be more prone to develop bacterial overgrowth. We lose stretch, and we lose blood flow, which can lead to vaginal dryness. And so several options. You can do vaginal estrogen. There are multiple commercially available options. There's actually a commercially available DHEA, which works on 3 layers deep. So it's working a little more than the estradiol will. It's called Intrarosa. And then hyaluronic acid is a non-prescription that can also be used if someone really doesn't want hormones. These prescriptions can be used safely in women who've had breast cancer, or for people who aren't a candidate for systemic hormone replacement therapy or just don't want it. So these are great things to keep in mind, but they can also be added on to a regimen of systemic hormone therapy.
Here's a practical superhero. So myth number 7 is I've tried vaginal hormones and I still have sexual pain. There aren't any more options. So we have the pleasure of having some fabulous pelvic floor PTs in the house. Thank you for taking care of everybody. I think that I think a couple things to keep in mind. So let's say someone saw their GP and their GP has them for a whole 7 minutes and they've got to check all the boxes from the stupid insurance company, and they write them a Vagifem prescription. The Vagifem is deposited right in the middle of the vagina and may not drip down enough to really get their urethral opening. And so they may actually still have like a urethral carbuncle or a lot of introital pain that's not adequately treated by the Vagifem tablet, or another example would be the S-string, right? It's really convenient. You stick it in and you're good for 3 months, but it doesn't drip out. And so I always have this conversation, look, I know you're going to send me a message and you're going to say that it's ooey gooey and you don't like it, but there's something kind of fantastic about the ooey gooey, is that the whole opening of the vaginal area gets treated. But I think when people have failed one thing, there's a lot more to try. So like Kate mentioned, estradiol acts on 1/3 of the vaginal epithelium, whereas DHEA acts on all 3 layers. So it's a great rescue when estradiol alone has failed. Unfortunately, 1 in 3 women in this country have had some sort of unwanted sexual contact. So has that person had an opportunity to address trauma? Is that something that needs to be worked on with maybe EMDR, a sex therapist, a trauma therapist? Do they have a vulvar skin condition that's gotten missed? I see this a ton. I think that, when I did training on the south side of Chicago at a Catholic charity hospital, I was taught how to catch a baby, how to cut out a uterus, and how to cut out a baby. And I had to go get vulvar training. We didn't do a lot of vulvar training. And I think a lot of lichen sclerosis and lichen planus is getting missed. If you don't know what it is, it's okay. If there's white stuff on the outside skin, send them to Sarah Corley at UNC. She's a vulvar dermatologist, and she's fantastic. If you've had sexual pain or vaginal dryness, you may have started off with a mucosal problem and have developed a secondary musculoskeletal problem, right? So no one says, I'm going to tense my shoulders and I'm going to keep tensing them and I'm going to keep tensing them, and then by 4 o'clock this afternoon, I'm going to give myself a really good migraine. Nobody does that, right? And nobody says, I'm going to not breathe diaphragmatically and clench my teeth all night long and pull my pelvic floor tight, so that when I try to have sex tonight, I'm going to be in pain. Nobody does that. So pelvic floor PT can be wildly helpful. And vagus nerve work, again, trying to reset the autonomic nervous system, get people out of the pain cycle, can be really helpful. So it takes a team approach, and I'm just so grateful for the pelvic floor PTs, because y'all are amazing. If you're trying to find a pelvic floor PT and you don't know where to look, this is the Herman and Willis site. So Herman and Willis does a lot of training for pelvic floor PTs. So this is a way you can find people in your area.
So myth number 8, hey Arnold, all libido issues are fixed with testosterone. In some circles, this is sort of the Bible, that if you take testosterone, your libido will be great. But think of women with PCOS who have high testosterone. We don't see them having these amazing libidos across the board. So it's just a little more complicated. In 2019, there was a paper that came out that looked at a number of studies using testosterone in women, and results were really not linear. And on average, it showed an increase of slightly less than 1 sexually satisfying event per month for women who were on testosterone at physiologic doses. Some women had almost no improvement. Some women had more than that. And so really it's not linear. I think there are potentially, I think this is on the next slide, some other potential benefits of testosterone: mood and neurocognitive improvements, muscle, lean body mass, and bone health. But we just don't have great data, and we have some data that looks really mixed. So testosterone is not currently FDA approved for women in the United States. Hopefully it will be one day. It can be beneficial for a number of things. Women sometimes report feeling much better on it subjectively, but we need more information about this.
And we prescribe testosterone. We do both compounded testosterone. There's a new formulation for men called Testo. It's a nasal gel. It's 5.5 milligrams, so it's not an insane dose. So if you've got someone that's maybe been on pellets and they've been on really high doses and you're trying to get them down to a physiologic dose, it's an option. If you're uncomfortable using a compounding pharmacy, that's also an option. But we check levels and try to keep people in physiologic ranges, and then have a really frank conversation like, hey, sorry, I'll let you finish the thing.
Well, Well, the conversation that we have is that libido is really complicated in women. And so, I mean, we've already talked about sexual pain and trauma and all of that, but these are 3 really great resources. Many of you may be in a position where you just don't have the time to have an in-depth conversation. There are great books available. There are sex therapists that are available. So lots of different options to support women.
And I just will give a shout out. I don't know if you guys know Lori Brotto. Lori Brotto is a Canadian psychologist. Our clinic partnered with her on an app called eSense. So Lori Brotto wrote Better Sex for Mindfulness, and then she wrote the Better Sex for Mindfulness workbook. So Lori has an 8-week mindfulness-based program that has a 63% improvement in sexual dysfunction. And low libido is the most common kind of sexual dysfunction. So I always really encourage patients to take advantage of behavioral resources in conjunction with hormonal resources. But be on the lookout, because her app is going to go commercial now that they've got data. So she's fantastic. She's fantastic. We're all clinicians.
Heard of that Rosie app?
Oh, I don't know Rosie.
I should check it out.
Yeah, it is.
I've never checked it out, but I've always, like, I hear about it on OMG.
Yeah, it is. Rosie app is done by
OBGYN.
Mary Claire Javier.
Uh-huh.
And it is amazing. It has a lot of resources about erotica, the stories, and for people with low libido.
Cool.
So it is amazing. Y'all should check it out. The
Thank you.
Rosie app.
That's awesome.
And Lori Brotto is amazing. Yes.
I'm just going to be a girlfriend for a minute and say, she wrote this paper that I just want to put around the universe. In 2022, she wrote a paper on the heteronormative influences on low libido in women. And she kind of started off with a story. And let's call this lady Jane. And Jane went through infertility, and she spent, all of the retirement she'd never made trying to get pregnant. And she had miscarriages and IVF and a lot of medical trauma to finally get pregnant. And then she finally gets pregnant, and she has twins. And there's a lot of medical trauma there, probably a lot of pelvic floor things going on. And then she has a partner that's just not really around. And she hasn't slept for 4 years because she has kids that are crying through the night. But when we meet, what did we call her? Mary, Sally, whatever we called her, in clinic, we're medicalizing her low libido. And I would argue that her low libido is due to low social support, which isn't a medical problem that we need to sell her something. We need to change our culture. So, but Lori wrote that article. And anyway, she's on our team, guys. Okay. I wanted to touch on a couple new things. So there are plenty of folks that can't take hormone replacement therapy. Maybe you have estrogen-sensitive cancer. Maybe you had COVID and had a blood clot after COVID. And even though transdermal is not supposed to cause clotting, maybe you're not comfortable, which is reasonable. There are a couple new things that you can try. So Veozah was FDA approved, I think, last year. Veozah is a KNDY neuron agonist. So right when estrogen goes down in our hypothalamus, the KNDY neurons go nuts, and that's why we make a hot flash. And so this is a non-hormonal medication that antagonizes those to stop the hot flash. It works pretty well. It's about 85% reduction at 12 weeks. Patients will start to notice an improvement within the first week. Main thing to know is you have to check liver function. So the data doesn't sound super scary, but 1.2 people out of 100 will have significant elevated liver function, up to 3 times the upper limit of normal. They did this study in the pandemic, so the control group also had 0.7 people out of 100 having that significant liver elevation. So I'm sure a lot of people were having fatty liver, were having alcohol, whatever. But you have to check liver functions every 3 months while they're on it. But I have several breast cancer patients who are on it, and they're getting relief. It's obviously not going to protect their bone and their brains and their heart. It just treats the symptom. But if we can get them to sleep, then maybe we can get to the gym, right? It's expensive, but they're coupons, and I think it's $30 with a coupon, and the rep will come bring you samples. So,
and there's specialty pharmacy too that you can order.
Yeah. This word's really hard for me to say. I'm going to call it E4. So if someone's pregnant, the fetus's liver is making a new kind of estrogen. So this is a bioidentical estrogen called E4, right? So we have E1 to E2, E3 in us. The baby has E4. There are no babies that are harmed in the, right? They're making this in a lab, right? But E4 is having a neutral effect on the breast, and there are actually several papers where E4 has been used to treat breast cancer. It does not have any venous thromboembolism risk, so this is really exciting. It's been in phase 3 trials. It was presented in phase 3 trials in 22 and 23 at Menopause Society, so I don't know why they're stuck. E4 is in a birth control pill called Nextstellis. It's drospirenone, right, the progestogen that's a little bit anti-androgenic with the E4. Yeah. So they haven't done the menopause bit. They went the birth control route first.
So this is the last one, myth number 10, is that you have to be in menopause 1 year from your final menstrual period before you start hormone therapy. This isn't true. Perimenopause can last 2 to 8 years, and women can start experiencing lots of symptoms, insomnia, hot flashes, all of them during perimenopause. I mentioned that in perimenopause, for women who have depression, hormone replacement therapy can be as effective as an antidepressant. It also can help with restoring sleep, improving mood. They're, preventing osteoporosis for women who are already osteopenic or at risk for osteoporosis. This doesn't mean that we go, throw patches out for people to use. I think doing this thoughtfully, assessing a woman's risk, looking at the rest of her life, making sure that the issue she's experiencing isn't really coming from something else that we can address, but it can be really appropriate to give these women hormone replacement therapy, maybe starting with progesterone and then moving on to estrogen when appropriate.
And then we just have a couple of things. So Kate's new to my team. This is more to learn about Kate. This was our talk for the general public last night, so y'all may not want this stuff. This is our Are We a Good Fit? So this is our kind of online class to see if people are a good fit for a patient and how to do a discovery call. So
Kate's amazing.
Kate is amazing. So thanks, guys. Do y'all have any questions?
Just a quick question about what you just put up with the HRT during perimenopause.
Yeah.
Are you finding lots of breakthrough bleeding or just irregular bleeding if you're doing HRT? I mean, I can picture if you put in a Mirena, then you could give them perhaps a little extra estrogen or something. But I'm just picturing HRT doses during perimenopause is going to lead to some wackadoodle bleeding.
Or they're going to have wackadoo bleeding anyway, and that's a conversation that you have. But yeah, the Mirena and a patch is what a lot of folks are doing because it's kind of plug and play and you don't really have to think about it. A lot of people are seeking us out, not that there's anything wrong with the Mirena, just because they don't want it. Mm-hmm. And so you can cycle their progesterone. You can.
Is that what, are you using like prometrium?
Yeah, we're using prometrium and a patch when it's needed, and then letting people know, hey, your body's on this roller coaster. You may be having crazy bleeding anyway, but the amount of estrogen that you're getting is so much less than their body is making, right? It's just such a low dose that typically they're not coming in like Shark Week at all. But it's a conversation to have. We all know what that means.
I was also wondering if you have people who, let's say in menopause, they're not really having hot flashes, night sweats, but they're saying sleep problems, and you probably could help them with prometrium. Do you have many people who are just wanting progesterone, but not necessarily needing the estrogen? And what are your thoughts on that?
I don't know how you feel about our options to treat osteoporosis, but I think they kind of suck, right? So like bisphosphonates have that 13-year half-life, and maybe they're more fragile bone and all the stuff at the dentist.
You like them on a little estrogen to help their bone.
I sure do. I want to prevent that bone loss. What the mortality risk of having breast cancer and dying and being on hormones and having not being on hormones, the mortality risk from dying with breast cancer is the same. The mortality risk in the United States, if you fall and break your hip, is 22%. So if we're really looking at mortality, why are we not being more aggressive about protecting women's bones at their time of most accelerated bone loss?
I second that, because because I feel like estrogen is needed even if the patient is asymptomatic. By the way, I'm Yasmin. I have a menopause wellness clinic too. I run a menopause clinic, so I'm like Polly, but I just do menopause and sexual health. So I agree with Polly that it is needed estrogen along with progesterone, and more so in perimenopause. I use cyclical regimens that you can just use 10 days of progesterone and give them bleeding if they're not bleeding heavy. But in post-menopause, you can keep them on a continuous regimen so that they get protection for sleep, and then you give estrogen for their bones and their joint pains and osteoporosis and all of that.
Are you guys trying to, at 60, wean them down, or are you keeping them on indefinitely, or what?
So,
I mean, I know that the data right now is like, probably up until 60, the pros could outweigh the cons, but I'm just curious if you try to wean them at some point, or whether you're fine.
so NAM's position statement that we reference says their position statement is benefits outweigh risk for the first 10 years of use and or 60. So whichever, like if you started at 45, you're good until 60. We know that your bones are going to go back to as if you'd never taken hormones within 2 years of stopping your HRT. And there's emerging data, it's still very confusing. So, right, the Kronos early intervention trial was a 0.05 patch. I think it was 200 milligrams of micronized progesterone. They did a follow-up of that cohort, and they presented that at Menopause Society this year, and they found it to be neurocognitively neutral. But it was like from women who are 50 to 65. Most of us don't have dementia when we're 65, right? So I really still feel like the jury's out on neurocognitive protection. We know that if you give me an oral prothrombotic agent when I'm an old person, I'm probably going to have a baby stroke and I have more neurocognitive damage. But what we don't know and what we don't have data on is if I start at 50 and you keep me on it, what's going to happen to my vascular system? What's going to happen to my brain? We don't know, right? And so it's shared decision making. Our consent is 3 pages long, and it's hey, this is what the position statement is. This is where the research is, and this is what my opinion is.
And you're talking about consent for even giving them prometrium and an estradiol patch?
Yeah, I consent patients. I think we're OBGYNs, right? We were sort of taught a little bit of a defensive medicine, but our consent's pretty warm and fuzzy when you read it. So part of our consent is also talking about, hey, if you're really trying to work on your hot flashes, what are you doing for your blood sugar? How are you managing your alcohol? What are you doing for your exercise? So this is one piece of your postmenopausal journey, but it's not the whole thing. And are you kind of making a commitment to yourself to do the lifestyle piece?
So I'm going to echo that one because I feel like I'm Amy Walsh from the Family Practice Doctor. We are missing the boat on diet, exercise, and lifestyle, and all this stuff. We can talk until we're blue in the face about which hormone, which preparation. But if you're not taking care of yourself and you've got 30 or 40 years or 50 years in front of you that you're already behind the 8 ball, no hormone is going to make you feel 100%.
We're all talking about illness, but we're not talking about wellness.
It's like you cannot replace a healthy lifestyle with anything. And that's what I have that conversation with our patients all the time. But it's like, if you are not eating right and you are not exercising day after day, year after year, you're never. It doesn't matter. Your bones are magic. Yeah. There's no magic. There's no magic.
Hey.
And so I usually get the, so I'm Chelsea Gongay.
She's
Shannon's
the
next door
best.
neighbor.
She's the
Love her.
best.
So, yeah, she's my next door neighbor. Thank you so much for inviting me over. Yeah, we're next door neighbors. Yeah. Are you serious? So I love her, just to let you guys know. Awesome. Love her. Your office just called me and I need to make her.
Well,
Thank you. So I think that what your point was amazing. So I'm a cardiologist. So I get it after they have not done what they were supposed to do. And I get a lot of clearances from patients about, oh, my OBGYN wants to put me on therapy and things like that. And some of them have risk factors for coronary disease. Some of them actually have coronary disease. And then some of them are like, I'm only comfortable taking a topical regimen. And so for me as a cardiologist, we never went to school for any of this. And they're asking me these questions like I'm going to know what to say. And I'm like, I don't know. I'm like, what did they say? And so I'm like, I had a patient the other day that asked me. And she was like, can you do a topical? So I'm like literally up to dating all these different things, and it's really great to have a resource to be able to look to. Yes, exactly. And so it's like, it is. And like, when we were in school, it was like, no, you can't do any hormone therapy. Like, you're going to have a heart attack if you have hormone therapy. Yeah, and then like as I got older and then did like more research, we realized that was not necessarily the truth. And so it's like these patients that are really really suffering that do have some risk factors or do have coronary disease. How do I give them the resources they need to make an informed decision about what to do?
NAM's position statement is going to cite all the observational studies that say that we don't have an increased thromboembolic risk in women who are using transdermal. They allude to the fact that the synthetic progestogens undo the positive effect of estrogen on the heart. So oral micronized progesterone is better on the heart. There's a nice paper from Felice. We'll have to connect because I have a bunch of questions for you. We could be buddies. I would love to be your buddy. So I think what we do, like if I have a patient who is outside of NAM's guidelines, so I have a 65-year-old, like some of my 65-year-olds in my practice could kick my butt any day of the week. They're really fit. They're doing a great job. I'll get a coronary artery calcium score, right? And no, if it's clean and it's 0 and it looks gorgeous, I feel pretty okay about giving them transdermal estrogen. I think transdermal estrogen is pretty low risk. But I do that as kind of a precautionary thing for people who are coming in, and I'll say, look, a lot of the benefits for you have sailed, but 15% of women are going to have hot flashes through the end of their life, right? So if we're cutting everybody off at 60 and saying, oh, your carriage turned into a pumpkin, there's a significant percentage of women that are really suffering. And I would argue, what is the health risk if they're not getting continuous sleep, right? If they're waking up 2-3 times a night, are they going to go to the gym the next morning? Probably not, right? They're exhausted. They're going to probably reach for that refined carbohydrate to get some quick energy. And what is their neurocognitive risk with not getting quality sleep? So
now that coronary calcium score is very mildly elevated, like something that I'm not really worried about.
Like it's 30?
Yeah.
Then I would do her MESA score, and I'm going to call you, and we're going to have a conversation. And we're going to involve the patient. We're going to say, hey, look, we're in an area where we don't have a ton of data, and sometimes you make quality of life decisions, right?
I agree with Polly. I do the same. If we use HRT for 10 years, and if they're cross 65, I would need a cardiology assessment and a CAC score, like a coronary calcium score, and an evaluation by a cardiologist. And then we have a shared decision making, like this is what we have found. When you are on this HRT, either we drop the dose or we kind of keep you down, we keep you on the same dose. So it needs a conversation and a shared decision making once you use it for 10 years of your HRT.
And I think
there's no like a cutoff.
Amy, like sometimes we'll drop people and then what happens, right? Oh, I feel absolutely fine. I don't have joint pain. My brain's working. Everything's good. They may want to wean off. And then if maybe they drop their dose by half and they're like, no, the dragon is back. Like then we just answered our question and they're a lot more motivated to say, hey, let's.
I just wanted to ask, speaking of dragons, it's like going along, everything's fine on an HRT, and then a new dragon pops up. Like, what do you do about that? It depends on, so
like someone whose hot flashes have been well controlled and then they're on HRT and then all of a sudden they're not controlled.
Everything's fine. All of a sudden, they're not sleeping, and brain fog. Just those two things.
And they're still on an HRT?
Yeah, they're on HRT, and for 10 years, everything's fine. And then she's laughing because we were the patient.
Do you want to?
I would want to see what else is going on. I would want to see what their labs look like. I would want to see what's going on in their gut. I would want to see if they have some other markers on blood work that are elevated. Yeah. I mean, I think not everything about the way we feel in menopause is related to hormones. And I think sometimes it's easy to get really tunnel vision that it's like it's hormones, we just need to change the dose, or it's the hormones aren't working anymore. But I think, back up and think what else is going on.
What's your cortisol doing? And is your cortisol causing insulin resistance? And what's your blood sugar at night? We'd put a CGM on you and try to get some more data about what's going on. I see some women that come in on birth control pills and they're complaining of hot flashes. I'm like, girlfriend, you're on a horse dose of hormones. It's not a hormone problem. We got to look for another source, right? Is your thyroid okay? What's your cortisol doing? What's your blood sugar doing? We got to figure out that answer.
Mm-hmm.
One of your slides talked about the gut microbiome, and I'm just wondering how menopause affects it. I think that's what it said, right? So I'm just curious.
The weight trend, all the weight.
So
How menopause affects
menopause.
the gut microbiome.
You want to do this, or you want me to try?
You go for it.
So we're all still learning about this, right? And so we just want to kind of welcome and know that we're all still learning about the gut microbiome. We're doing a test called a GI map test, which is maybe not, some people are not comfortable with, which is fine. It's not an FDA approved test. There is something called the estrabolome. So there's a whole group of bugs that are related to estrogen. And so that's going to change as estrogen levels change. But I think that we're all still learning about this, right?
From a functional perspective, what are things that you're noticing?
I think that.
Specific?
Well, I think we know that
There's a lot of SIBO emergence.
Yeah, so hypochlorhydria,
So when you have lower estrogen, you have less gut motility. When you have less gut motility, your digestion's affected and you're more likely to develop SIBO. So I see a ton of SIBO in my mid-40s, late 40s, early 50s.
And is it fixed by going on estrogen? Or
No.
It helps it. You need to treat it depending on how severe it is. But once you treat it, the problem with SIBO is it's got a 50 to 85% refractory rate. So if you've got a woman who's got, her main trigger was, of course, stress. Perimenopause, a ton of stress, right? So that's a main trigger for SIBO. But if you've got a woman who you've treated SIBO and her stress is better, if you want to try and prevent refractory SIBO, hormones are usually a part of that.
And sometimes we need pelvic floor people, right? Like it's all such a big web, right? So am I super stressed out? I'm clenching my pelvic floor. Therefore, my gut doesn't move as normal. Stuff's growing here that shouldn't be. Like I think functional medicine gets really into small biology, and sometimes we need big biology friends to look at the structural piece.
I would just like to say that while you said that, I had to relax my pelvic floor.
We didn't see that. If you put somebody on, if they're perimenopausal and you put them on estrogen or what have you, is there a way to prevent the SIBO issue or side effect of having low estrogen?
I mean, so SIBO is, you're right, you've got stress, you've got type A personalities, there's more to it than just hormones. But I see SIBO mainly in my populations at teenage years, so men are, for those who are susceptible, and then I see another surge. So, and there's a study that came out last year, and again, we're just learning about it, but looking at the gut microbiome in women at different ages, and there's significant changes that happen. And there's probably changes that happen in women too, because your gut microbiome turns over so quickly. So there's significant interaction, but we're just learning.
And like think about that kind of clinical scenario that Susan just brought up. Like I don't know about you, but I had terrible skin when I was coming up. So what did they do when I was around menarche is I got put on doxycycline, right? And then as we're in perimenopause, we have this little minute where our testosterone pops up, and a lot of us will develop periorbital dermatitis, periorbital acne again. And what happens? We get put on doxycycline again. So there's this hormonal thing, and then the stress is crazy, and then sometimes there's pharmaceutical stuff that's adding to this, and then we layer on COVID, right? COVID's a disaster for the gut, so it's complicated.
Yeah. Can I go back and ask you about like what would be I would say the aware of or that they didn't want to tell us about.
Yeah. So I know there are some people in this group that use pellets. I don't use pellets because I don't have that kind of level of hubris. So I'm just going to be kind of a human being for a minute. So I kind of feel like the mom is the middle of the family. Like if we fall apart, the whole family falls apart. Maybe that's old fashioned, but that's how I feel. And so if you give her a pellet, and she has rage and she's got teenage kids and that family unit falls apart and she comes back to your office and says, I'm a disaster. This is a disaster. What have you got to tell her? But sorry, it's going to be disaster town for 3 to 4 months. That's not acceptable to me. And so the other question is, I started taking hormones when I was 40. My mom went through menopause at 38. I started changes at 39. And so these pellet companies would come want to sell me their pellet. And I said, cool, you understand the pharmacokinetics of how that pellet is absorbed into fat. But I'm a young person. So if you're going to put this pellet in my butt every 3 months for the next 20, 30, however many years, do you understand the pharmacokinetics of pellet through scar tissue? Do we have any studies on that? No. They just wanted to sell me some $30,000 Theragun that's going to magically break up the scar tissue and take away my cellulite. And I'm like, dude, this isn't right. So we don't use pellets. We're going for physiologic doses. So if someone comes in and their free testosterone is 0.1 and they've gone to couples counseling, they read racy novels, they're doing all the things, and they're like, look, I feel like, one woman told me, she said, it feels like he's touching my elbow. Okay, I might give her a little testosterone. I said, hey, we can try it. We can also try some Scream Cream, right? You can use a topical vasodilator and see if we can get a little bit of help there. But yeah, I mean, it shouldn't feel like your elbow.
Holly, what is your favorite testosterone? You say it's like, you mentioned that nasal thing is new, but what is your go-to?
So we're pretty conservative. So we usually use Triangle Compounding Pharmacy because they do they're an accredited compounding pharmacy and they do the training for the accreditation for the state. And so we start at 4 milligrams per milliliter. So each click in a Toppy click is 1 milligram. So we do 1 milligram and then they say nothing happens. And they say, great, then we can go to 2 milligrams. So we're really slow. When they get to 4 milligrams, we'll check their levels. We want to get a peak drug level. So within an hour to 2 after putting the cream on, they get a drug level and they want to make sure they put it on the backs of their knees that day so that we're not putting on their arm and getting contaminated specimens. So we're really conservative. We start low and some patients leave me because I'm so conservative. They're used to pellets and they want to move much quicker.
I'm a menopause specialist too, so I deal with testosterone, and every menopause specialist have their own protocols and the way they deal with testosterone. So what Kali is saying is we start very low and we slowly build it up. So it can be a cream like what she compounds in Triangle Compounding Center, or we could also use androgel or androfem, which is available for the male. It's very high dose. ISHWISH is an organization which is called International Society for Study of Women's Sexual Health. So you can go up and look up the testosterone guidelines there, which they have recommended to use in postmenopausal women for low libido. And we use 1/10 of a dose, which is like the androgel. We ask them, we dose it in such a way, like between 2 to 5 milligrams a day. Like, we can start at 2 and then slowly you can build it up to 5 and 5 milligrams a day. And we give it at the back of the calf or the inner thighs and we check the levels. The key piece about this is you have to monitor the blood levels every 3 months or every 4 months just to keep it physiological and not really go like the pellet ways of like 300. Some people do pellets, like the gynecologists do pellets, but the difference between the companies that are really selling these pellets and gynecologists is we keep them within the physiological limit, like with below 100, below 60, below 80. We don't push them to like 300 and 600 and 800, which is what these patients are getting, and they land up in the ER with blood clots and with all kinds of hairs on their face, and their clitoris is almost like a penis. Which is, clitoromegaly is permanent and it never goes back to normal.
When you say permanent,
Yeah, it is permanent. Yeah. So we see those bad effects what Kali was saying. So pellets are really bad because they have to be handled in a very, really, really cautious way. Because it's not something that you can play around with that because these patients can mount a huge response and you just have to back it off.
Do you find that it changes their lipids at all? The dose?
Yes, it does. It does. It is adiposity can increase in your midsection, your body fat can increase in the midsection, and your lipid, your total cholesterol can go through the roof.
Typically that's for oral. So in the NAMS position statement for oral testosterone, it should have a negative effect on lipids. Transdermal shouldn't have a negative effect, and that's in that position statement.
Yeah. And the pellets do raise the lipids so much.
Thanks, y'all. This was fun. Thanks so much to Dr. Scholl. Tell me what you need. You want that one. Okay.